everyone. Thanks for Department of Medicine going around. It's a great pleasure, but also great honor to actually take a last two going around for cardiology. We're fortunate that we have this time. Our study faculty is native. Years ago, 10 years ago, right? Or 16 years ago. Wow, okay. What big commitment he has made to the program. So years ago, he joined us as a non-invasive cardiologist. Patient care. Very interested in research. All the lifestyle can very active publication, no international presentation. Just sort of after export in this field. Into level. Preliminary study on lifestyle change or heart attack. The teacher here basically win the most insider lecture by the residents actually just a couple weeks ago. So we're forced to listen. Heart failure, they are all on the renal burden as well. Okay, great. Anna, without further ado, I think we're all yours. Thank you. Yeah.
Thanks so much, Dr. Lu, for giving me this kind introduction. It's a pleasure to actually stand in front of our colleagues and have a conference after years. Thanks so much, Dr. Hankover, for being here in spite of starting service. Can you hear me back there? I'm hoping on Zoom also people are able to join us. So today's discussion is on heart failure with preserved ejection fraction, the real burden, understanding the diagnosis and management aspects. Disclosures are High Life, which is our non-profit trying to help people understand these concepts holistically. Seeking Hunger is the 30-page book to help people understand self-inquiry a little better. The objectives for today's discussion are what the diagnostic challenges we face on a day-to-day basis in HFpEF, what is the contribution of excess weight, and cardiac hemodynamics, how it is affected by the body weight and by the weight loss. Heart failure, can it be reversed? This is the newest exciting effort that we are starting. I don't know of any other group that says HFpEF can be reversed. Future of cardiometabolic optimization. So all these things we're going to touch upon today, and hopefully we'll have plenty of time to have question answers as well. The diagnostic challenges start here. These are the Framingham diagnostic criteria for heart failure that came out in the 1970s based on Framingham population in the 1960s, when obesity was such a small proportion of the general population. Now it is a huge deal. Half our population is dealing with obesity. Nearly 75-80% of our patients have excess weight issues. So this is a much, much bigger challenge now than when the criteria came out. Then why do I put this Framingham criteria still now? Because even today, the diagnosis of heart failure is clinical, and we still rely on these very basic concepts that you see in this picture. The major criteria being pulmonary edema, cardiomegaly, neck vein distension, crackles in the lungs, S3 gallop. Still, this is what we go by. And the minor criteria are dyspnea, ankle edema, hepatomegaly, nocturnal cough, and tachycardia. And then you can use minor or major criteria as you need it for weight reduction of 4 kilos in few days because of diuresis. So this is how we still diagnose heart failure. 1 in 3 deaths today is because of heart-related problems. We have about 6 million adults in the US with heart failure. Every year, we have 1 million hospitalizations. This is the number one reason for unexpected hospitalization in Europe and in the US in this day and age. We spend over $40 billion in heart failure management. But when we say heart failure as cardiologists, we only focus on the heart issues because that's what we are experts at. But the patient is not only here for the heart problem. Lot of times, 2/3 of the time, they have mobility issues, pain issues. Majority of them have challenges carrying out day-to-day activities and hygiene issues. And mental health is a huge deal to start off, and it only gets to be more of a problem when they get hospitalized. Yeah, it just came back. Thank you. Now, we say this diagnosis of heart failure, which requires hospitalization. We said 1 million people in the US alone annually. But what about what happens to them at 3 months? Readmission rate is close to 30%. Mortality is already at 10% within 3 months. It is close to acute ST elevation MI, where we call the helicopter, get the cath lab activated in 30 minutes and do stenting. In heart failure, it's not that acute, but the mortality is nearly that significant. And if you look at 1 year, more than half the people are back in the hospital. 1/3 are mortality. And by 5 years, this is more malignant than most cancers in this day and age. 75% of them are already lost at 5 years, once they have the first hospitalization for heart failure. Then one other thing to remember is the ejection fraction. We say if the EF is low, it worsens our prognosis, but this metric applies whether the EF is normal or reduced. That is the challenge in heart failure. Whatever may be the EF, when somebody is admitted for heart failure, the risk is the same. We'll go to a specific patient who was hospitalized here. This is not a hospital.
I'm going to interrupt. Excuse me, the screen is not shared. I'm going to fix that. Maybe. Martha, it's not taking my escape to give us the option to share it. No. It was working, yeah. Here. Yeah, we just have to be able to get to it.
Oh, okay.
Yeah. No.
So just put escape.
How about you?
Yeah, put escape.
It's because it's recording, I wonder. I'll go sit back down.
I'll just minimize the screen first.
Yeah, now we can. Okay,
Yeah.
share screen.
Yeah,
Perfect. You can go to the slides. Gotcha. Can you
Resume.
confirm with someone? Yeah, that I can do.
Yeah.
Thank you. So this was the message that heart failure at 5 years has mortality more than most cancers. So this is a 64-year-old who was referred to us for an echocardiogram. She had developed some leg edema and trouble breathing, as well as fatigue and palpitation of 2 months duration. There was no chest X-ray, but echocardiogram was ordered to rule out heart failure by primary care physician. Patient had undergone 2 surgeries in 86 and 2007. And despite that, in 2007, you can see her weight reduction, but then all that weight and some more came back. And now in 2022, her BMI is still around 48, which is severely obese. So anything more than 35 is severe obesity. More than 40, we say super obesity, morbid obesity. And the comorbidities I'm not even going to read. She has most of the chronic diseases that we talk about. And I'm only reporting her echocardiogram. I'm not the clinician taking care of her. So as the echo comes through for rule out CHF, I showed you the Framingham criteria. Can I rule out CHF on the echo? The answer is no, because it still is a clinical diagnosis when echo was not even available in the 1970s. So I said, based on the patient's symptoms which are present in the echo, I can say that certain features may suggest heart failure of obesity. So this is how our journey into this challenging thing started recently. When we do the echo on her, the pulmonary pressures are not that impressive. Diastolic parameters that we check, E by E prime for wedge pressure equivalent and certain other things as cardiologists we learn, even that wasn't that impressive. LA size maybe was a tad bit bigger. And we said maybe there is some diastolic challenges. But her cardiac output, which is normally about 5 liters, for this patient was nearly twice. So this we said, patient would benefit from an actual cardiology consultation for obesity HFpEF assessment. So this is one of the first patients about 6 months ago that we actually started saying in the echo report. And now this has become a standard for many of our providers here, because we want to capture these people before they get into too much trouble, or after some years, the chance of making a change in the natural progression gets so much lesser. So we want to capture these people soonest that we can. And this we recently published. It's a very simple algorithm. Basically, all that we need is the BMI and the patient's age. Dr. Alpert, who recently retired, is the father of obesity cardiomyopathy, because here from Mizzou, he wrote the first papers in the 1980s. Even before we learned about heart failure with diastolic dysfunction, HFpEF, he had already written about obesity heart failure. So this literature has been growing with us. Along with the growth in obesity, we are only learning more and more about obesity cardiomyopathy. One aspect of it is the HFpEF obesity cardiomyopathy. So in blue, what you see is Dr. Alpert's cohort, which are young people. You can see the age is only 35, but their BMI is so high, it goes to 60, 70. And then in this lowest circle, you see the traditional group of heart failure with HFpEF population. Their age is between 65 and 80, and their BMI is around 30, 32 on average. And then what is this yellow group up here? This group is very unique because Mayo Clinic took 10, 15 years of their data on HFpEF and captured that group that has specifically obesity-induced HFpEF. So this was published about 3-4 years ago. We combined all those 3 groups and drew this line. That's all we did. And we reported that line is along the point of BMI plus age crossing 100 at any point. So a 50-year-old when the BMI is 50, or a 35-year-old when their BMI is 65 are at risk for HFpEF. That's what we are saying. So anybody, including the public, can look at their risk based on just their weight and their age. So this gives us this pink group, which is the elephant hiding in the room. So many of our population have so much weight issues, and they attribute their symptoms of trouble breathing, or even their leg edema, or even their kidney issues to their weight and or their arthritis or so many other things. They don't attach it to heart failure. Unless we do the cardiac catheterization, unless we do the diastolic stress echo, we may not even diagnose heart failure for 5, 10, 15, sometimes even longer number of years before we make the diagnosis of obesity, HFpEF. So the benefits of this system of very quickly making a screening test is, we know symptoms are multifactorial. Exam is so limited. All those S3 Gallup, many of these crackles, they are so non-specific in the obese patients. And we want to remind everyone that obesity does not need any other thing like hypertension or old age. Just by itself, it can stiffen the heart and cause heart failure. And all the tools we have to diagnose diastolic dysfunction in the echo lab, E by E prime, tissue velocities, mitral inflow velocities, PA pressures, everything can be normal in 1/3 of the diastolic heart failure patients. Cardiac catheterization is invasive. It's not easy to do a heart cath on everybody when we suspect these things. And it's unreliable because many times to get them to lie down on the cath table, because without lying down, we cannot do the heart cath. And for them to do that, many times they get Lasix. So you get a normal LV end diastolic pressure in the cath. But in real life, their heart pressures may be going up on a day-to-day basis, especially if they're trying to climb one flight of stairs. So just ask your patients, when is the last time you were able to walk a mile or climb a couple of flights of stairs? They will say, oh, doc, it's been 25 years since I did it. Today morning, one of my patients said that. That is where the heart failure is hiding. So obesity heart failure can also be diagnosed if they get a lot better with weight reduction. So that is the other thing that we are now experiencing. So next, what is the individual cases that we want to discuss today? So one of these patients came to my clinic, and then I just went back into the records. In 2020 is when I'm actually seeing the patient, but I went back for about 15 years, which is available in our medical records. From the age of 60, she has had dyspnea, angina, and when you see EDP, it means she has had heart catheters to exclude coronary artery disease. EDP of 17 is high, 26 is very, very high. And then the most recent CAT says EDP is not that high. So it's because of the medications. And lung pressures have been high, left atrium is big, and even that keeps changing back and forth. So patient had shortness of breath, chest pain, and coronary events in these 15 years. And in 2020, she started our mindful eating program to try and holistically lose excess weight towards cardiometabolic health. And in 2022, her age has gone up by 2 more years, but she reports to us she's feeling like a 25-year-old. So like we don't have any metric. Even the KCCQ or heart failure scores, whatever we have, doesn't measure this much perceived improvement. So we just use this, and we haven't, in the last 2 years, come up with any better tool than just reporting how young they feel. And her BMI has dropped from 35 to 26. So that is the real difference that has happened to her. And this is her story. Within 6 months of starting our program, she lost 36% of her weight. And this is from our medical records that you can see in 2020, where her weight was 104 kilos. You may think is not that much, but for a smaller woman, that's sometimes a lot. That BMI of 36 that she had was causing a lot of trouble. And this is when she reported feeling like 25. And then you may say, okay, you did something on, and then real life happens. We know anybody who loses weight regains it in 1 year or 2 years. So now we have 2-3 year follow-up on her, and her weight is still staying off, despite her coming home and finding her totally healthy son without medical or mental health issues had committed suicide at home. He works at a pet shop. And she tried to do CPR. She couldn't revive him. And despite all these real life challenges that our patients go through, she remains optimistic and positive towards life itself. This is what our biggest study, Look Ahead, that was published in 2013 in New England Journal. In high risk for heart failure patients, because of diabetes and obesity, they said, we want to do aggressive lifestyle change. We will give people what to eat. Specifically, we'll package the food for some years and make sure they get low calories, and we'll make them lose weight. And this is the group that they tested. And this is the result. At the end of several years, between controls and the study group, there was not that much reduction in heart failure or coronary events. So they said, lifestyle may not make a big difference in heart event risk. So we need to find more medicines. The weight loss that they achieved was only 6%. And this is what we feel is the current role of lifestyle in reducing weight, less than 10%. Study failed not because lifestyle failed, but because the targets they achieved were not big enough. We need much deeper weight reduction to make actual difference in the natural progression of the cardiometabolic problems. That is achieved by gastric bypass surgery. This is from Sweden, the SOS study that was published a couple of years ago. And what we know from gastric bypass surgery is obese people, morbidly obese at the age of 30, 40, maybe 50 at best, if they undergo surgery, they can regain 50% of their life that they have lost. How much have they lost? 7 years people are losing because of excess weight. And half of that they are able to regain if they undergo gastric bypass surgery. But it has to happen around the age of 40 years. If we delay it to 60, 70 years, surgery is becoming too high risk with too many comorbidities. And gastric bypass surgery is not easy for heart and kidney patients and the comorbidities that we deal with day in and day out. But at young age, if they get the surgery, it returns back life. But why is that? It's because compared to the placebo, gastric bypass patients lose about 20 to 30% of their weight initially, and then about average 15 to 20% is sustained 5, 10, 15, 20 years down the road. So that is how they are regaining the lost years. When we used the mind along with the body, the holistic methods that we started here at our VA in 2015, we called it Heartful Living. We emphasized what we call self-inquiry. So this program has much deeper connotations, in the sense people gain that confidence and optimism. And now since the pandemic started, all of this is on Zoom and it's recorded, and we've made it free for anybody anywhere to view in English. That's all we have. And in 8 weeks, we cover so many things about diet and exercise for half an hour, 15 minutes. We practice some mindfulness and 15 minutes of specific question answers to tailor it to their own needs. But over 8 weeks, they've tried 20, 30 different mindfulness methods at home with their family. And they gain that confidence. Okay, I can make some changes in my perception of life itself. So that is where this program really makes a change. And compared to lifestyle, which is at 6%, and bariatric surgery, which gives us back 50% of the weight-related loss of life, we are already at 25, 30, or even more percentage weight reduction. But our results are all anecdotal. We don't have a prospective randomized study yet. So that's where we are moving towards with our holistic program. So how does it work? In one slide, we teach self-inquiry, which is asking the question, who am I? What is life about? And that gives some meaning in their life. Last week, we enrolled a patient who said, the only thing that I have to fight for is my 3 cats. I said, that's great. You have 3 cats at home that want you to come back home, and we can help you from there. And she said, okay, Anand, if you think that's good enough reason for me to live, let me try smiling. That's what we ask people to do, smiling and connecting and finding that optimism within themselves. And then comes slowly they find that strength to do some exercise on their own. We don't enforce this many footsteps or this limitation of calorie counting, Fitbit. We are not asking people, because our patients are a lot of times older with not that many sophisticated tools to manage their lifestyle. Asking them to get blood pressures checked and bring them back in a month office visit, that itself is a big favor they are doing us. So when they make these changes intuitively, their heart health improves, their weight loss becomes much more intuitive and sustainable, and they gain the confidence to move forward in their life. So that's how our program works. So we use these Siddha self-inquiry concepts because cardiology gives me the ability to deal with acute MI and heart failure and hopefully improve lifespan. But when we bring about holistic concepts like integrative medicine, we can work on health span. And when we do sports and martial arts and dance, we are connecting at the subconscious level and working on creativity. When we teach meditation, we can work towards higher consciousness. Yoga checks off several of these boxes, but yoga is not directly translatable in the acute care setting. When we just teach self-inquiry, because I teach it only as a cardiologist, so our simple Siddha self-inquiry works on gratitude and smiling and using our own inner nature to be a little more hungry. That's all we teach. And in the end, it's able to check off all these boxes from acute heart failure in the hospital towards all the way up to reaching higher consciousness. So all this we are now starting to report and starting to formally test. I'll take it through one small sample from a medical text in Siddha. This is not by Tirumular. It says, Andam Suringil Adarkor Arivillai, Pindam Suringil Pranam Nilaipadam, Mundi Suringil Ubayam Palapala, Kandam Karutta Kabali Mami. This is the 5,000-year-old concept. This was written about 2,000 years ago by Tirumular. And what it means simply is, when we choose to turn our attention inwards, we wake up at a deeper level. When we choose to lose excess weight that is in our body, our life lengthens. We can live 100 years. And then after we've attained the normal weight, which may be a BMI of 25, after that, if we choose to try eating a little lesser, then the benefits are too many. This was 4,000, 5,000 years ago. Even then, they said it detoxifies not only the body and the mind of all the challenges, stresses, and anxieties, and it also elevates consciousness. So this is the invitation from a medical text several thousand years ago. And this is our cohort of patients who had a BMI of 65 age of 65 and weight of 125 kilos. And within 2-3 years, they are losing about 25% weight despite having heart failure. So this is what we recently published. And we are showing cardiac dimensions getting better, kidney function getting better, and the PA pressure is all improving. So weight reduction, if we achieve significant weight reduction, so for that, it might be 15, 20, sometimes 30% is what it takes to change the disease progression. This is a busy slide. We don't need to go into too many details, but what we are saying is in these mindful eating methods, the benefits are both at the mind and the body level. We are improving insulin sensitivity through calorie restriction, natural ketosis, which we are suspecting at this point when we published this, because we weren't measuring ketone levels 3 years, 4 years ago. There are a lot of benefits in molecular level, anti-aging mechanisms, and optimism itself reduces the stress that comes from the central nervous system onto the heart. In the hospital setting, that's what we are working on. Better diabetes control, better blood pressure control, and through weight loss, heart failure gets better directly. So this is what we are seeing as a reason to reduce rehospitalization. So what about in the hospital setting? How does it work? This patient was admitted for 2 weeks, maybe 3 weeks at Lake Regional. And when he came to my office, because his wife was my patient, he said, I won't get admitted here. I just got discharged 3 days ago. And I won't have the kidney biopsy or the heart cath, because he needed all those things right away. His heart function was very weak when he presented. It was only 25% EF. But within 3 months, he was able to cut back on his Lasix. His EF improved. His severe mitral regurgitation became only mild. And after being on the wheelchair for several years, he is now taking 4,000 steps every day and doing some upper extremity weight training and several hours of yard work. Basically, he's feeling much, several decades younger and confident. And what about that cath and that kidney biopsy? His brother had kidney complications during biopsy or early dialysis, and they lost him. So he said, I will not go through any kidney procedure, even if it means my life. So some people carry their burden from their family issues. So he never had it. It's been several years now. It's been 2.5 years. So he's still not had those procedures. But this is a story. He's still around, doing great compared to 2020. So he started fasting for about 20 hours, 2 times a week. His weight was extremely high, 156 kilograms. That was a lot. But his diuretic requirements have come down. Within 8 months, he lost 8% of his weight. And that's when he reported, I'm feeling much better and able to do 4,000 steps. But now it's been 2 years or 1.5 years since then. And now his weight loss is at 20%. And he's doing even better. He's going to come next week to our office again. So this graph I expected to go down further. And we are not forcing it. They are doing it on their own intuitively. This is his kidney function. This is when at Lake Regional, they said he probably needs this biopsy to figure out what's going on. His BNP numbers are getting better. His echo is getting better. So that is what we are seeing. And people who need hospitalization, who are acutely ill, they are getting better with these things. So what about cardiac hemodynamics? So what is the actual mechanism through which this cardiometabolic intervention works? So this is that simple slide that tells us. To get this one slide, it took 30 years of gastric bypass surgery, 40 to 50 kilogram weight reduction through gastric bypass surgery in people who did not have overt heart failure. They might have had occult cardiac hemodynamic abnormalities, but what they saw in this group is heart rate reduced, cardiac output reduced, because after gastric bypass surgery and losing the weight, you don't need that much cardiac output. Pressures are going down dramatically. Right heart pressure is going down, wedge pressure is going down. So basically the heart is thanking the person for having the gastric bypass surgery. This has been going on for 30 years. This is a recent publication that compiled 30 years of data from the Mayo Group. And so we are saying we can work on reversing heart failure if we catch it early enough. How early? If you look at most of the Western developed nations, like European Western countries, where obesity is at 10 to 20%, US is head and shoulders above the rest of the world, developed or developing. We are at 30% obesity and we are still climbing. In the next decade, we are going to cross 50%. Of the entire US adult population is going to be a BMI more than 30. This is staggering numbers for a country. And what do we have for treating HFpEF, which is the bread and butter of cardiology care? The number one agent in the most recent 2022 guidelines is a metabolic agent. It's not a cardiac medicine, SGLT antagonist. That is what is there as a class 2A indication. The other agents that we use in the traditional heart failure patients, like ACE inhibitors, RNE, and mineralocorticoid antagonists, ARBs, they're all maybe beneficial, but even for doing several long, good quality studies, the benefits are so minuscule compared to challenges that they are facing. What about fluid restriction? This is what our cardiology group is now going to take off. Although the study was published 6-7 years ago, the study looked at randomized trial for fluid restriction. And they said there's really no difference by reducing fluid intake. So we can allow people to have at-lib fluid intake, so 2 liters, 3 liters, whatever they want to drink. Please make sure it's just water. It should not be energy drink like soda or Gatorade or other things in the hospital, because sometimes because of the diuretics we give them, they call their family and say, hey, I'm so thirsty, they are restricting my fluid. Can you please get me some Powerade or Gatorade into the hospital? So they drink that in the inpatient setting. So that gives too much salt load. So basically, as far as water, it's actually safe to give a decent amount of water intake. We don't have to restrict. So now we are going to take it off. In the 4 East on the doors, it says 2 liter restriction. It's going to come off because that's what we know. What about beta blockers? This is one other thing we use. This study was done in Spain. Patients came back to their cardiologists and thanked them profusely for discontinuing the beta blocker. This was the one agent we said increases time in diastole, maybe lesser stiffness, and people can exercise more. The reality is they exercise more when they stop the beta blocker. So we are really rethinking how we understand heart failure. So this we started in 2008. We got a grant to study same thing, heart failure with preserved ejection fraction. My hope even then was to reverse it. But at that time, I thought it is through exercise. Even now, cardiology thought leaders think it is through exercise. But our success has been not through exercise. Exercise has to be a side effect or something people do out of their confidence. Not by forcing exercise, we cannot make the heart less stiffer. That is what I personally feel after being in this area for last 15, 20 years. But we were able to show in people, why is this patient using the bicycle in his hands? Because veterans a lot of times have back issues or don't have a leg and they just can't do the traditional rehab. So he's undergoing cardiac rehab using upper extremity, home, tailored rehab. Now you're hearing more of it in the pandemic era because cardiac rehab is moving more and more towards online. But we started this long ago here at our own VA. So this is looking busy, but what it says is, earlier we thought it's a heart problem. Now we are thinking heart failure is not even a heart problem, it's a metabolic problem. That's what the most recent thinking is. And what we are saying is, for a 95-year-old, heart failure can happen because of natural stiffness. But if it's happening in 70-year-olds, it's because they had hypertension for a long time. But if it is happening in a 30 or a 50-year-old, lot of times, look at their weight currently and their weight over the last 30 years, they might have had a lot of weight burden. Excess weight can directly lead to stiff hearts. That's what we are finding in our practice here. So how do we move forward from what we know today? Earlier we said congestion, so give Lasix. Inotropy, give digoxin, give dobutamine. Then we said hemodynamic is the issue. So more agents to improve the blood pressure. Neurohumoral inhibition, which is ACE inhibitors, beta blockers, spironolactone, all these things are excellent for poor EF patients, which is only half the heart failure. Half the heart failure patients have stiff hearts. And for them, the number one reason may be, or is most likely, inflammation. On top of all these things, the EF is preserved, so you cannot use inotropes. Hemodynamically, sometimes it's challenging because their blood pressure is also okay. You cannot do too much when it's okay. And neurohumoral manipulation is not easy. Congestion, it's not easy because we have some nephrologists sitting here. They don't like when we use diuretics. Cardiorenal syndrome, that is the big problem. It's a bad word in heart failure because half the patients with heart failure with preserved ejection fraction develop cardiorenal syndrome, and those have double the mortality in that hospitalization. So if we can preserve the kidney function, we want to. How many trials have been done in those half of the patients who develop cardiorenal syndrome in the last 20 years? Maybe 1 or 2, that too not prospective. So it is so little we know about how to manage cardiorenal syndrome. It happens in half hour, which is 500,000 patients every year getting admitted. So this is the challenge, and inflammation may be the key, how we address it. So this is the grant that we recently submitted to the NIH. Hopefully they will fund us. We want to do calorie restriction, encourage plant-based foods, a little bit of mindful meditation. And exercise comes after they go home and learn these things. But when in the acute phase or in the after the discharge, when they learn these things, they give themselves a chance to reduce their inflammation and not only improve their lifespan, but also their quality of life. So that is where we really want to make an impact in our patients' lives. So this is one of the patients that was in one of the publications. This patient has 3 cardiologists. One of them is in Barnes Jewish, because if she gets so sick, she needs a procedure, our surgeons feel she's too high risk, she goes there. So in our hospital, she was admitted 15 times. At Barnes, at least once here she was admitted. And after she learned our mindful eating methods, she has not been admitted for the last 15 months. That is the power of anti-inflammatory diet and mindfulness, despite all the best evidence-based therapies that we have. So this we feel may be one of the mechanisms going into ketosis. This patient was intubated, but because hemodynamically unstable, we could not initiate tube feeds. That worked out good in our favor. The patient is cardiac, heart failure, coronary event, is being intubated and managed. So we just checked the ketone levels and we are reporting it. We didn't do any other intervention on an intubated patient, but the ketone levels went close to 1. And we invited Ronnie Nelson. He's one of the pioneers in cardioenergetics. What he did in Europe is he injected ketone into the vein of heart failure patients and published this in the top cardiology journal Circulation. Last year, he came and gave grand rounds to us. And what he says is IV ketone works magic. What the magic is improves cardiac function without increasing the workload. It's like the car is going faster, but without consuming more gas. When the gas price is this high, we'd love to use less gas, right? So that's what happens when ketones are given to the patient. Why? Because carbohydrates, fats, they're all good source of fuel for the heart. But ketones may be even more preferential, especially when the heart is failing. So that's what he published. But that's only 30 patients, and that's too with an infusion, and it's still not available. It's not going to be standard of care until somebody takes it up and does some studies on it. But what we are achieving is intuitive, natural ketosis. This happened because the patient was intubated, but this is happening now because we have an IRB-approved protocol to teach people. The food is not taken away from our patients. We give 3 meals and whatever snacks they want, but we go and tell them in the hospital, try and please eat a little lesser. Understand being hungry is healthy and it's helping your heart. And if you see the age of some of these people, it's mind blowing. They are very young people coming in with heart failure, and they're trying these simple things to gain their health. So this is what we are seeing. Their ketone levels are going up, and we are very encouraged because I don't think anybody else in the world is doing this type of cardioenergetic studies. And this is what has happened to one of those patients who tried this. The high sensitivity CRP became half in about few days, 4 days it declined. This is a patient who our dietitians were very concerned because albumin level had gone down to 1.7. And when I taught this patient, he's only 18 years old with heart failure. So he's not even in our protocol because we kept the protocol EF for 55% because we wanted to study some people who have a chance of benefiting. This kid is only 18, but his EF is 15%. He had surgeries and so much going on already. But our dietitians were concerned that if he doesn't eat enough, he may get malnourished and his wound healing may be delayed. But this kid is also struggling with very severe cardiomyopathy, heart failure, and so many other challenges. So he was discharged within a few days, and he's doing so well in our last 6 weeks. He has lost so much weight, so that we'll keep it for a separate presentation. But what is happening to him is this. His albumin level has actually come back to normal by eating lesser. We don't know the mechanisms. I have to spend more hours on studying all this, but he is getting better by putting less food in his mouth, and he's doing it holistically. This is the weight that was measured in the last. He turned 18 in this hospital. He came in with heart failure, such a prolonged months together hospitalization, and now he has lost His weight now is 135 kilograms. He's lost a ton of weight. He has lost a leg also, so that plays a role into why he lost that much weight. But basically, the kid is happy to be alive. So simply to summarize everything, we want people to connect with their optimism first. Try not to eat for at least 12 hours at night. Maybe a little bit of tea, coffee is okay. Water is actually a friend. We don't need to restrict it in the hospital or at home. We ask people to smile and avoid snacks and all the drinks in the world except water. It's not a headache or a knee pain. Being hungry is actually a sign of health, especially for our hospitalized patients. If you want 6 more tips which go into our mindful eating methods, having food nearby actually helps. It helps me also. And then we are not starving anybody. It's only a choice to stay a little more hungry if they can comfortably do it. We ask people to walk often, even in the hospital setting, because walking mobilizes and improves cardiac output. And when people try these mindful eating methods, they may not even be on cardiology service. And we are only making our teams more familiar. So they have to discuss with their doctors, especially if they are diabetic. And when they try to go hungry for a little bit, it engages their imagination. They feel so empowered because they've already lost so much of their physical abilities, their independence. So when they learn, okay, I can be a little more in control of my health, it means a lot to them. And the standing blood pressure, I'll come back after we start our grand rounds and I'll talk about it. There's so much we are learning about it. We are sending abstracts out, but I need much more time for it. So we're not going to go into that today. But many VAs are taking it up because we started in the VA system and because it's on Zoom, some of the leading VAs in California and Texas and Florida and Boston, they are referring their patients to our program and they are embracing it and starting it. So we'll have some good quality data in the next 2-3 years, hopefully. So this is a very small publication, but it's got a lot of impact. We said adolescents at the age of 15, if they are optimistic, throughout life, their risk of coronary problems goes down by 75%. And it was taken up by the popular media and 94 million people viewed it. So people want optimism. And when our patients get more confident, empowered, and start doing better, it translates to their whole family. That's what I wanted to share here. If you ask me in the hospitalized setting how our program works, the gratitude reduces sympathetic stress. The fasting, which is main key, leads to ketosis. But importantly, even otherwise, if we don't eat for 16 to 20 hours, that's the equivalent of likely 80 milligrams of IV Lasix. That's what we've known for 30 years. We don't know the full mechanisms behind it, but that is a very proven and powerful system. Directly, it works like diuretics, and it reduces the risk of postprandial angina. The reason is anytime we consume food, our heart has to work harder to digest the food. So if we are not eating much, and people with extreme obesity, they can go without food or lesser food for a few days while they're in the hospital to heal themselves and reduce their in-hospital mortality and learn these holistic things that they can embrace after they get discharged. So this is how it works, by reducing systemic and pulmonary vascular resistance, improving cardiac output, and they get into a little bit of ketosis, and EF also can improve. But EF improvement doesn't matter for HFpEF because their EF is fine to start with. But for reduced ejection fraction patients, that can be a huge difference because they are improving the contractility without the cost. Because dobutamine is available. I mean, now we are in this pandemic where everything is in short supply, but typically when we need dobutamine, we can give it in the vein. Then why don't we use it on everybody? Because it increases oxygen demand. It actually increases arrhythmias and ischemia. Whereas if they go into ketosis, they can gain that benefit without increasing the workload on the heart. So all these are the mechanisms that we are asking NIH to support us to do the study. This is a 50-day continuous fasting, which happened 2-3 years ago. And we learned a lot from this patient. We were still not checking ketone levels, so we don't have his ketone levels, but he fasted for 50 days. He had LV dysfunction from coronary artery disease, 2-vessel disease. We diagnosed it and we said, you need surgery. We called the surgeon. He said, tomorrow morning we'll operate on you. Because you have critical disease and you have LV dysfunction, you have 400 units of insulin every day. It's not, none of this is going to get better with any lifestyle. But this patient said, I attended Dr. Chokalingam's 8 weeks program just now. I want to give it a shot. They said, I told him, I was the attending. I said, you learn our mindfulness, but you already attended 8 weeks, but let's do the surgery. After that, you will have plenty of time to participate in mindfulness. He said, I'm just going to go home, try it and come back. We didn't realize he's going to go 50 days without food, but he drank only water for those 50 days. Last 3-4 days, he got so weak and dehydrated. He had to be in the hospital. Even there, he refused glucose. He only got his electrolytes through his fluids. And after 50 days, he started eating. And these are the numbers we just reported. And the reality is, out of 20 medicines or so, he needed only 1 or 2 for years after that. So he didn't ever need that bypass surgery. We did stress testing on him 1 year later, 2 years later. The LV function improved, and he didn't need a heart catheter because he didn't have angina. So basically, he didn't keep that appointment with the heart surgery. Can we recommend this? No. We are not asking anybody to go without food for more than 20 or 24 hours at maximum. 23 hours is what we need, because they can have lunch, and next day if they can have lunch or dinner, that's perfect. That's what we recommend in the hospital or at home, because beyond that, there are other issues that come into play. We don't want heart patients or anybody to even go beyond 24 hours. We get all the benefits when people do 23. But at 50 days, we learned a lot from his story, and we published it. This is one of our head nurses in our hospital who came to me a few months ago. She is 64. She plans to retire at the age of 65. She had new development of leg edema, pulmonary hypertension. Her PA pressure of 30 went up to 60 on the treadmill. And we did this calculation. BMI of 35 plus age of 64 comes to 99. So it's very close to 100. We said, you probably have heart failure. And then we did the stress test. It confirmed that her PA pressures went so high. So I told her, you have obesity-related HFpEF. And look at her weight. She's not 200 kilograms like some of our other patients. She's only 88 kilograms. Is that good enough to cause obesity-related heart failure? She's a smaller person. So that weight was good enough to cause the trouble and the BMI of 35. We didn't do any surgery. We didn't do any magic. She's a nurse who's still working in our hospital. And this is what's going on with her. Her BMI is now completely normal, 24, I think. She's feeling 20 years younger, and we can honestly say her HFpEF is cured. How can we say that? She's off the Lasix. Her treadmill time has gone from 5 to 10 minutes. She's feeling 20 years younger, and her blood pressure medicines are now coming off that she's been on for years. And she still wants to retire next year. And then instead of having a 75% mortality by the age of 70, she now has a chance of actually traveling around the world, which she wants to do with her husband. So this is the change that is potential. And we are the only people even talking about excess weight as a contributor to HFpEF at this point. This is the heart surgeon who gave the appointment to our patient. Dr. John Martley is the chief of CT surgery at our VA. This is him a year and a half ago. Within 10 months, this is how much weight he has lost, which is 43% of his actual weight. And he himself feels that he wouldn't have even imagined that there is another aspect of his life until that weight goes off. Then you don't, because that once you carry it for a long enough time, we don't realize how much burden we are carrying. So once he lost it, now he feels, wow, this is the shirt I fit in when I was only 20 years old before I went into medical school. And he's actually running and walking combined, I think 10 miles or even more every day. And he's doing weight training. He's loving life. He wants to come and operate with fun without back pain or neck pain or other issues that he had a year ago. So this is possible for many of our colleagues, for our patients, for our nurses, and everybody who's interested. This is the most exciting patient because I don't even know this patient. This is another cardiologist in our group takes care of this patient and gave our material digitally, and he viewed the 8 hours of material. And his weight was 235 kilograms. When he started our program, his EF was only 25. In the last 1 year or so, from the feeling like a 57-year-old, he now feels like a 20-year-old. That's because his EF is now gotten up to completely normal. And he's now going through surgery. He's being scheduled because he has so much skin tags. They want to make him look cosmetically better, but his energy level is off the roof. He's so happy and doing so well, and he wants to promote wellness in his family and his friends. So this is the potential of what we are talking about. I want to thank so many of my friends here and in India who have helped me, from nutrition, exercise physiology, Siddha experts, and nephrology, psychiatry, cardiology, machine learning team that is helping turn a lot of this into digitally deliverable things so that without us directly involving, patients can embrace these things safely. And we think we are at a crossroads where we can make a big change in a holistic way in cardiometabolic care, and much of it can be delivered online. Blood pressure is such a huge deal. Along with HFpEF, when we address these things, we can make the whole world a blue zone. What is special about these blue zones? People live extra 15 years without all the sophistication. They are all very hardy people in Italy and Japan, very remote islands. So people there in those remote islands can live 100 years and healthy. Definitely with the latest technologies, we can do just as well or even better. Thanks so much.
They are, I'm sure, very motivated to do the same. Very healthier. Things that about 10 minutes. Questions that we can discuss after we come. And then you talk about, oh, sure. Great talk. And my question is that now when you're the patient of fasting, do you monitor the calorie level or no?
This is the big challenge, because when we take away the food from them, we know as cardiologists, NPO for a heart cath, they don't like it. If they give them NPO for a stress test, they are saying, doc, I need my food. It's their right. So we don't want to take away their right. So the way we've designed it is the food will come in the hospital just as usual. We don't interfere with the food prescription. We say heart healthy diet. That's all we are saying. But we tell the patients, you learn to be a little more hungry, because in the hospital setting, you are able to measure your sugar levels, your blood pressures, everything we can monitor and guide you the right way to become more intuitive. So basically, we are not prescribing calorie cuts. In the last 7 years that we've done these programs, we've not measured their calories at all. All of this happens intuitively.
Just for body weight, that's all.
Body weight is a side effect.
Sure.
Yeah.
Now, one major concerns for patients losing weight, especially very obese, diabetic, now more worry about metabolic abnormality, for example, potassium level, maybe kind of doses, acidosis, if you do not have the regular meal.
This is very similar to gastric bypass. If you go deeper into gastric bypass surgery, what happens is people are taking 800 calories after 2 months. So in the first 2 months after gastric bypass, they are slowly advancing from nothing to soft liquids to slowly getting up to 800 calories. So even after months, they are taking very little. For us, ours is simple, holistic, and instead of taking the cut first, we slowly do the cut. So the body is acclimatizing throughout. So they're reducing their medicines with their endocrinologists, their primary doctors over several months. So the graphs here are in a longer time span. So when it happens over months, the body is able to manage it better. Obviously, their diuretic is the first thing we end up having to stop, because the blood pressure drops too much and electrolyte imbalances with that. And insulin, if they are on it and if they want to try this, we still haven't made that collaboration with our dietitians and our endocrine colleagues to ensure that we can track this at a good level. But that's what we need moving forward, so that even diabetics on insulin for 10 years, we can safely navigate this journey. So far, my patients who've done this have done it on their own, who are on insulin, because we don't recommend getting off the insulin or doing fasting. For diabetics who are on a lot of insulin, the only thing we recommend is trying to embrace more plant-based anti-inflammatory foods. We don't recommend fasting at all to avoid the risk of electrolyte and avoid the risk of ketoacidosis or hypoglycemia, which can be life-threatening and can also cause arrhythmias and other problems in cardiac patients. So that's something we've stayed away from.
Questions?
I started it in 2018. This Heartful Living program started in 2012. Officially in the VA as a whole health group clinic, we started it in 2015. And veterans get travel pay since 2015 to come. But since I myself didn't even have an exposure to it until the summer of 2018, I've not talked about fasting until 2018. From 2018 until the rest of my life, I'm going to be hungry, because it's making me healthier and I love to play tennis. I can play 3 times a week tennis until 2018. Now I can play 6 or 7 days. My wife is here. She would like me to play 7 days a week. So I play 6 days a week. The thing is, my joints are taking it better because we play on hard cement courts in Colombia. I'm 48, so it's not easy for the body to recover. I feel the inflammation is much lesser in the body because I do intermittent fasting. What I do is about 14 to 16 hours on most days. And once a week, at least I do 24 hours. And that gives me the sort of confidence to look people in their eye and say, it's okay for you to try it. I'm doing it. Many of my colleagues are doing it and several patients have now done it. But in 2018, when I started, it wasn't easy to convince people to even try it. But we got so many people who trusted us and tried it. And now we have published it and now we have momentum behind us. So we can do a lot more moving forward. Yes. The word fasting is a type of calorie restriction. There are several of my patients who don't do fasting because they have advanced liver disease or they have diabetes, and they succeed by still having 3 or even 4 meals a day, but they're reducing the quantity. So calorie restriction, intermittent fasting, anti-inflammatory foods, plant-based foods. So these are some of the key concepts that we emphasize. But again, as doctors and providers, for us, these things may seem reasonable and we go to the internet and find whatever we need to find about these things. But several of our patients, 60s, 70s, 80s, they're so hard, so many challenges they are facing, it's hard. So when we make it so simple for them to embrace, then it makes it a little easier for them to try. But once they get better, they're breathing a little better, then they're hooked to it and they try to, why not get even better? So like that, positive feedback starts for them. There are 5% of my patients took it up in 2015, 2018 timeframe. So it's not good. Now 80% of my patients are taking it up. Even now, 20% of my patients say, doc, you just do the stent or you do the procedure. I don't want to do anything else. But at least 80% are trying, and half the patients at least are getting the dramatic results you're seeing here. And the best thing that works for them is if they have at least 3 cats at home that they care for. If they don't, today I met a patient who's here with his daughter. They live in this town. He has 2 daughters. And he says, and the daughter also says, he's given up. He's only 65. Last year he was doing this year he's not. So he says, no, I've lived enough. I don't have anything else to look forward to. I just sit and watch television. His kidneys are failing. His heart failure is still there. And he's got back only 5 kilograms compared to last year. But others in the program are losing 25 kilograms in this last 1 year. So I told him, I'm here to support you if you want anything I can offer you. So that hope and that optimism at some point has to come from within. If that is there, the rest of the magic we will support them through. Cats are good, dogs are better. If you have some family, it's so good. Some friends who will do it with you, that makes it definitely a sure thing. Oh, okay. Do you use GLP? Yes, GLP, SGLT. As a cardiology community, a lot of us are only now learning to use these for heart failure patients. And if they are already on it, so far, I don't mess with it because I don't mess with any medicines. In this group clinics that we do at the VA or wherever we teach it, I'm a lot of times not even their cardiologist, so I can't even reduce their Lasix, so they have to go to their own cardiologist to do it. But for my own particular patients, I don't even then manage any of their endocrine medicines. And I tell them, if you're on insulin, you might have to talk to your doctors about cutting back on it on days that you want to fast. So if somebody wants to fast for 24 hours, they have to ensure they take plenty of water. And on the morning that they decide to fast, they should take half the dose of insulin. Roughly, you could say that for the long acting. Short acting, they may not even need that much, except if they're eating their dinner that day. But as for SGLT and GLP antagonists, we are not using that to gain more weight loss because I feel it's too many things on the plate. But if they're already on it, I don't mess with it. How to combat nervous eating or hunger while working at computer or watching television. So we are all working on the computer or watching television, and my patients, they're doing this all the time. So it takes 8 hours for me to answer that question. That's the 8-hour Heartful Living program. But bottom line is we connect with that confidence, happiness, something in their life that we ask them to connect with. And slowly once that, maybe once the ketosis, they develop a few times over the next few weeks, that itself reinforces through brain-derived neurotrophic factor and so many other mechanisms that we still don't understand. I have not spent any time on mental health issues. I'm going to give lecture at the International AHM conference next month saying we can take this higher consciousness tools towards PTSD and depression, but we haven't done formal studies. Only now we are working with psychiatry and psychology collaborators to get proper psychometric analysis. But we feel anxiety and depression, PTSD, they all get so much better. When a patient on 25 medicines is coming off 20, many of them are mental health medicines that they're just not needing anymore. But we don't promise that upfront. We let them explore it through their own experience of these deeper mind-body methods.
Anybody else have questions? Maybe one short one.
She has. I'm going to repeat your question so everybody hears it on the Zoom also. Her question is, we use the word keto. So what keto are we talking about? Ketogenic diet or other types of ketosis? There are several things we have discussed, but today we didn't spend too much time on ketogenic diets. The reason is we are cardiology by background, and ketogenic diet we fear increases cholesterol and inflammation, and it doesn't gel well with the heart. Although there is a lot of growing body of evidence that ketogenic diet produces weight loss. But what are we trying to lose weight for? Diabetes doesn't kill. The weight itself, how does it hurt our health? Through the heart and the kidneys. And they work on reducing inflammation. So unless I see some prospective studies, like the SOS study tells us clearly that gastric bypass surgery gives you life back. But that has to be done at the 30s and 40s. Like that, for ketogenic diets, we don't have. The American College of Cardiology and Lifestyle Medicine that I work with, we really believe plant-based diet and maybe Mediterranean diet and DASH diet for sure. These may be the best choices to reduce inflammation at the same time. And they are not ketogenic, these diets. When you say ketogenic, by cutting down on carbs, the diet becomes 60-70% fat and only 30% protein and very little carbs. So that's, I feel, is not great. And we now have a manuscript about a specific patient. We can go into details where ketogenic diet might have actually progressed her coronary disease. And after she switched to a plant-based our fasting meditation system, her things have cleared up so well within the last year. But I mean, these are all anecdotal cases. We need prospective studies, but by and large, we don't recommend ketogenic diets. What about ketone supplements? Like I said, one of our stars from Europe, he gave ketone in the vein. Why don't we do that? Again, for everybody to embrace it, there has to be prospective studies. So we don't have that yet. I don't know if somebody is even considering doing more studies in heart failure. And again, it's going to be an infusion. Okay, now there are other ketone salts and esters that you can ingest and raise your ketone levels. That might be a good alternative, especially for normal weight people who have heart failure. But if there is excess weight, we can get double the benefit by teaching them the holistic way of losing weight while they get into keto. So it's like getting 2 or 3 things done at the same time. So being in the hospital, we may achieve so much more. So ketogenic diet, not good. Ketone supplementation may turn out to be something big in the future. But our way of getting into natural ketosis is the hardest way, unfortunately. But we've done this for 5-10 years, and we are confident that many people can embrace it throughout the world at this point. And we feel this will help our society move away from the obesity crisis the world is moving into.
For time, I think we have to stop here. If there are questions, I'm sure that will be a whole afternoon. So cardiology is not that easy, so we have 6 hours a day to exercise. So thank you very much.
Thanks so much.
That's great. That was good. I know that actually. Thanks so much. I think I was just concept like